So I can't emphasize this enough, that I share this belief. This statement was excerpted from the ATS-ERS document, that perhaps the most important component in successful pulmonary function testing is a well-motivated, enthusiastic technician. As you'll hear in just a little bit, I'm not sure I go quite as far as the standard way, the way I was taught to do pulmonary function was to yell at the patient. In fact, I was told, you'll never be successful at doing this unless you yell at the patient. In fact, you do better if you jump up and down during the course of a long exhalation. That'll coerce the patient to continue their efforts. We'll talk about that in a moment. But we're at a point now where we're going to begin monitoring technician performance and providing you with feedback on how successful you are at doing what you do. There's a lung study that was done quite some time ago to determine what were the effects of smoking cessation on lung function. Prior to this study, everybody presumed, but really didn't know, that there was a beneficial effect to quitting smoking. After this study, what we found out was that the accelerated rate of decline in lung function that most smokers experience could be or would be adjusted after smoking cessation to approximate the greatest rate of decline of non-smokers. That's what the study was all about. It was a multi-center study, a little bit of an ivory tower study. They used the same equipment across all of the clinical centers. But they did an interesting thing during this study. They divided those clinical centers up into two groups. One group, and they used standardized equipment which had software in it which gave a quality grade to each testing session. So if you did everything great and all the efforts were acceptable and all the efforts were, all of the two key parameters, FVC and FEV1, were repeatable, you got a letter grade of A. That was the best you could do. And so A is what everybody after training tried to achieve, and they were quite successful. These were university-based hospital PFT labs for the most part. And but the two groups they divided them into, this is how they treated them differently. In one group, they instructed the key technician to provide feedback on the letter grades that technician was on average achieving. And the other group, they just sort of let it go. Just, not give them any feedback. It's like, thanks, appreciate you collecting that data. And what they found was, over the course of the several years of this study, that the clinical center that got feedback maintained very high quality grades, that they were in the A to B category the majority of the time. And the clinical centers that were in the, hey, no feedback, you just keep doing your job, their quality declined and went to the B and then the C and sort of hovered C to D at some of those centers for a while. So the clear message was, if you provide feedback on how people are doing, they're going to maintain the quality. And that's something that I never forgot. I tried to do that in a small operation. It was pretty easy to do. In a bigger operation, we can go all day without seeing each other, and that kind of feedback just hasn't been happening. And I'm a little concerned about that, so we're going to institute something that we're going to enlist your help in. That is, we'll talk more about that later. So within the Cleveland Clinic Health System, again, in the effort to standardize, one of the things that we did a couple of years ago was to standardize the terminology that physicians would see when they were ordering the tests. And as we moved out to the regional hospital level, we found that they really didn't have this kind of level of detail on their PFT request sheets. And in fact, some of them would even they said, oh, everybody wants complete PFTs. And that's fine, but maybe it's not so final. But not everybody needs complete PFTs on every visit. And worse, amongst the 8 hospitals, there were 8 definitions of what comprised a complete PFT. In other words, complete PFT is not a universally recognized term. And we were instructed some years back by a Joint Commission surveyor to take our equivalent of complete PFTs off of the request sheet. We called them pulmonary function survey with bronchodilator. And that's certainly not a universally recognized term. People were just like, what's a survey? But it was a spirometry, a lung volume DLCO, so let's call it, we had the equivalent to what we saw in the regional hospital. All of that has changed within the last year. Now the regional hospital's PFT request lists look just like ours, with the exception is they may not have every single test that we do. Not every one of them is doing cardiopulmonary exercise testing, for example. So these are the different varieties of spirometry that you can order. Sorry about that. Baseline only is just what it sounds like. Let's just do an assessment of where they're at. Baseline and post-dilator says, yeah, I'd like you to give them bronchodilator after you do that baseline and then repeat it and let me see what the change is. Follow that with another one which is kind of useful, which is, I don't know this patient, and if it's normal, fine, you can stop testing, but if they show obstruction on their baseline value, let's give them a bronchodilator so we can assess their responsiveness. And then we have that sort of specific to the neuromuscular group, spirometry, upright and supine, which assesses the impact of change in position from upright to supine on the vital capacity. Really just looking at the vital capacity more than anything else to see if there's any evidence that the diaphragm is weak or exhibiting signs of dysfunction, evidenced by a reduction in the vital capacity. And then a spirometry before and after exercise, looking at a very specific patient population, those with asthma, that may have triggers or maybe eliciting a history that says, you know, I'm fine until I run and then I get wheezy. And then we try to recreate that in a laboratory environment with, I might add, some small success. We really, oftentimes the patient's history sounds very much like, oh, this is going to be a positive test. But for whatever reason, likely to be due to the fact that this is a clean indoor environment, and the temperature and humidity are very well controlled, aeroallergens are not likely to be at the levels that they are outside, so it's oftentimes a negative test. Certainly no change before and after exercise doesn't rule out exercise-induced asthma, it just means we didn't see it here in the laboratory. So spirometry, to long story short, is the starting point oftentimes for a diagnostic workup for a patient with respiratory symptoms. And it's a simple test. We're really looking at only a couple of parameters. I'm not saying it's an easy test. You guys know that. It's just simple. We're just asking the patient to breathe in as deeply as they can, blast the air out. Now the ATS-ERS document says there's a lot of uses or indications for spirometry, and we're kind of in the top two there. We don't do a whole lot of disability testing, although we have done and can do. Public health uses it for epidemiological purposes. They want to see, you know, people living in a certain environment where air levels of ozone are sky high. What's the impact on lung function testing? That's what they mean by public health. We're more in the diagnostic and the monitoring mode. Diagnostic, helping the physician determine what's wrong. Monitoring, following the course of the disease, or seeing if the patient benefits with the addition of some therapy. So this is what they highlighted. This is directly from a table from the ERS ATS document, procedure for recording FVC. So it really starts with what we do in the morning, as we said. We make sure the instrument is calibrated properly. It has to be done before we do any tests that day. Explaining the test to the patient. There's no one way that has universal success. This is what you guys get good at. You kind of read your patient. Is English their first language? How do I best describe what I want this patient to do? And you kind of tailor your instructions to that. We do need to be very specific and very precise. It's not enough to say, I want you to take in a deep breath. Well, a deep breath could be this, or this, or this, or this. We want them to take in their deepest breath. So precision in those instructions really is important, as well as coaching. Prepare the subject. Washing hands should have taken place, actually. I would put it a little higher up on the list. That's something you want to do before you go out to see the patient. Instruct and demonstrate the test. We usually don't demonstrate the test, but as you know, on those difficult patients where you're not having success in getting your point across verbally, oftentimes you'll take a clean mouthpiece and you'll do that. You'll demonstrate the procedure for them and create that aha moment where the patient goes, oh, why didn't you say so? Okay, I'll do that. And so there is some value in being able to demonstrate that for the patient. The recommendation is that the patient inhale completely. And this is the part of the standards where there really is no standard, right? How do you know when the patient is full? How do you know to switch gears from coercing them to breathe in more and more and more? I can tell you one thing you don't do is look at the screen. That is not the way to tell. On the screen, for everybody I think knows this, we're looking at a volume time tracing. And as the patient inhales, we're typically seeing that volume time tracing move along at a standard speed, but it raises up on one axis. And some people will look at that while they're talking to the patient, and the patient's not in their line of sight. So how do you know? Well, the answer that's been given to me in the past when I've asked that question is like, oh, well, I see a plateau on the volume time tracing, meaning there's no further volume change. Well, no further volume change would indeed accompany reaching total lung capacity, but it will also occur whenever they stop breathing in. So are they full? You don't know. So how do you know they're full? We'll talk about that in a second. All right, so you will have them pause for less than a second. Why less than a second? Anyone? Yeah, patients have a tendency to leak air. If you hold them at total lung capacity, if you really get them there, they're waiting for that command to blow. And while they're doing that, they're using their inspiratory muscles to maintain that high lung volume, and they're working against the recoil of both the lung and, importantly, the chest wall. They want to go back to a lower lung volume. So you make them hold too long, and you're almost guaranteeing that your patient isn't going to satisfy startup test criteria that we're going to talk about in just a moment. Remember, we always want to do a minimum of 3 satisfactory maneuvers, and the word in that sentence that I'd like to stress the most is minimum. It's not 3 and done. It's 3 until you get an acceptable testing session. Or you've reached the point of diminishing returns where you go, you know, no matter what I do, it doesn't bring me any closer to my goal of getting test results that really meet all of the standards. But you do know that you have a pretty good idea that you're getting the best the patient can do when the data, 2 pieces of data, achieve repeatability. Meaning the 2 largest FVCs, when compared to each other, differ by 150 ml, or 0.15 liters. And the same with the 2 FEV1s, the 2 largest FEV1s from that session. When they exhibit that same small difference, that means the patient was likely to be at the same starting lung volume, and you took them to the same point of emptiness, and they were blowing with the same degree of expiratory force. Otherwise, your FEV1s would not likely match each other. The expiratory times, we'll speak about this more in just a moment, but 6 seconds is the minimum. And for anybody who's over the age of 10, we're not a pediatric lab, although we do test a few pediatric patients. In that patient population, lungs tend to empty more quickly. There's nothing magical about the age of 10 that says, well, you know, you're 9 years old, Timmy. It takes you 3 seconds today to get all the air out of your lungs. Tomorrow, when you turn 10, it's going to take you 6 seconds. That's not the case. These are generalizations. We see some young people you know, in their late teens, early 20s, and sometimes into their 30s, who will empty in less than 6 seconds. So we take a little bit of license with that expiratory time, minimum expiratory time criteria, and go more towards one that we'll talk about in just a little bit, achievement of an expiratory plateau, meaning patient is exerting effort and there's really no or very little change in the collected volume. So this is what ATS-ERS summarizes, constitutes an acceptable forced vital capacity effort. Meaning without an unsatisfactory start of test, a back extrapolated volume of less than 5% of the FVC or 150 ml, whichever is greater. And now let's stop there for a second. I did intend to have a slide here showing that, and I apologize, I don't. I think most of you know what back extrapolated volume is, but essentially it's what Nancy alluded to when I asked the question, why don't you want to have that patient hold their breath at TLC too long? Extrapolated volume is volume that comes out of the patient into the spirometer. It's measured, and it comes out and is measured before the patient applies maximum expiratory force. And so we're saying that that can occur, but if it constitutes, if the amount that was exhaled constitutes more than 5% of the total volume collected, you really need to disregard the FEV1 that was associated with that effort. Your FVC is still valid if they did empty and did get it all the way out, but your FEV1 shouldn't be considered for use in reporting. Now, there's another standard here marked with an asterisk, and that's time to peak flow greater than 0.12 seconds. Time to peak flow addresses another question. It means after that back extrapolation of the start of the test, after considering, taking into consideration the amount that might have leaked out, the tiny amount that might have leaked out before application of maximum force, time to peak flow is saying how long did it take before we saw the peak flow associated with this effort. In other words, it's a measure of how explosive, for lack of a better term, how rapid the compression was. And so this used to be a big challenge in the laboratory. We know there's different mechanisms of obstruction, right? If I asked everybody in the room, I'm sure you could tick them all off. What causes airflow to be less through the tracheobronchial tree? You go down and say, well, there's bronchial spasm, there's inflammation of the airways, that narrows the airways, there's loss of elastic recoil. Loss of elastic recoil is a sort of a natural consequence of the destructive changes of emphysema. And in this patient population, if the time to peak flow is greater than 0.12 seconds, it generally indicates that they're not applying a very explosive start of test. They're doing a submaximal compression of the thorax. Now we know that the pressure's raised in the chest when you have a person do a forced vital capacity, when they're doing that initial maximum application of force. We know that the compression of the chest raises the pressure inside the chest. That does two things. It acts as a driving pressure to push air out of the lungs, but it does a second thing. It applies a closing force to the airways themselves. That's generally not a problem in people with normal lungs because there's a support mechanism. Those airways are embedded in the lung parenchyma, which has a lot of tiny elastin and collagen fibers that provide sort of a stretchy traction support of the airways, preventing them from collapsing. The destructive changes associated with emphysema sort of wreak havoc on that whole airway support system. So that when a patient applies an explosive expiratory effort during a forced vital capacity maneuver and they have emphysema and they've lost elastic recoil due to destructive changes, those airways literally flatten out. And that's responsible for that spike and drop to very low flow levels that we quite often see in our more severe emphysema patients. It's quite possible for a severe emphysema patient to show you within the same testing session an FEV1 that is around 0.5 liters when the effort was done correctly, and an FEV1 that's approaching 1 liter when it's done incorrectly without an explosive. In other words, they generate higher flows during tidal breathing than they do during the forced vital capacity maneuver. And so this used to be a challenge in the laboratory because if you followed the ATS instructions to always report the best FEV1 from the testing session, you would find yourself selecting an effort that showed a rounded peak flow, and you go, oh, this isn't right. It looks like this patient is responding hugely to a bronchodilator. Or this was in the pre-session, and now it looks like they did it correctly post because they're feeling better. And now it looks like they're having a paradoxical reaction to the bronchodilator. So that challenge has been overcome, I think, by adopting a standard that was suggested as being useful in the previous ATS Spirometry standards document. They fell short of recommending it as a standard, saying it needed further study, but we've been using it for several years. And for any laboratories out in the regional hospitals, if you're not utilizing time to peak flow less than or equal to 0.12 seconds as a start of test criteria, now's the time to adopt that. And I'll talk more about that in just a little bit. Intuitively, the second issue here, or the second bullet point, no cough within the first second of the forced exhalation. That's an important one. Without early termination of an effort, without a Valsalva maneuver, and what they mean by there is premature cessation of airflow due to glottis closure. So the patient still looks red or purple in the face. They look like they're pushing. Indeed, they are pushing. They've closed their airway opening. The spirometer is seeing no more collection of volume. The patient is experiencing now some negative effects that we'll talk in a little bit. Valsalva sustained for many seconds can cause you to pass out. Without a leak, meaning the patient is not blowing air into the room. Some of their exhaled gas isn't going into the room because they don't have a proper seal around the mouthpiece. Without an obstructed mouthpiece, it used to be in the days when the mouthpieces were made out of cardboard, it was possible for a patient, either during an effort or between efforts, to have that in their mouth and sort of bite down on it, narrowing the opening or changing the shape of the opening. And subsequent efforts after that bite, after that reduction in the diameter of that cardboard tube, could look like obstruction, could constitute a resistance to airflow. So, also the tongue sometimes can do exactly the same thing. Patients somehow, I find it difficult to do this myself, to put your tongue partway in the mouthpiece and blow through it while maintaining a seal, but some patients can do that. And without evidence of an extra breath being taken. And our software, for the most part, anytime it sees any inspiration, will terminate the further collection of exhaled volume. So that's generally not an issue. But I presented this because they made a statement of definition here, that they made the distinction between acceptable efforts and usable efforts. And so they're saying that if you meet all of the criteria on the previous slide, so everything that we've listed here, that constitutes an acceptable effort. But they said that if you only meet conditions 1 and 2, both of which center on the start of the test, really looking at the quality of FEV1, that you had usable data, meaning that and we subscribe to this notion that tests that don't meet standards, any or all of the standards, still carry some usefulness to the ordering physician. They tell them that, in spite of all the problems that we're detailing here in our notes, we did collect at least this much. And if that value that we're reporting is close to what's predicted for that individual, that's useful information for the ordering physician. So we do have some, we don't make a great, don't make a big thing about labeling the session as acceptable or usable, but they did make that distinction in the document, and I thought you guys should know. So this is the thing that I was asking about before. The starting point for the FEC maneuver, no particular standard addresses this. We have a saying that we use when we first start teaching you: if they don't breathe it in, they can't blow it out, right? I mean, we're looking, everything, all of those standards that I just addressed, really we're looking at the exhaled volume and ignoring the fact that if your starting point varies, your data is going to be variable, and you have no way of knowing if the data is variable whether or not it represents the patient's best. Now, people that have been doing pulmonary function for a long time have a tendency to think that you need to be loud when you do PFTs. I learned this a long time ago, and as I said, I was told I must be loud. So for many years, I was loud. And some patients didn't take that well. Some patients felt that if you were yelling at them, that they must be doing something wrong. And I have personally seen patients who were brought to near tears because they felt that they must be doing something wrong. Otherwise, we wouldn't be repeating the test over and over again, and this guy wouldn't be yelling at me. And so there was a change in our laboratory many years ago to go from yelling to just making sure that the tone of voice that you were using carried with it some emphasis. So there is successful coaching without a lot of volume, and we do that very nicely, and I thank you for that. I pride ourselves on being a laboratory that doesn't have to make the patient feel uncomfortable about their performance. So to get back to inhaling to TLC, what you're looking for is evidence that the patient, it really is full. You're not going to see this looking at the screen once again. When you think about it, once they get to a full lung, if you're coaching them to breathe in more, they are very actively engaging their inspiratory muscles. When the inspiratory muscles can't shorten anymore, then what you have is isometric contraction. That often translates into a quivering of the head or the chin. That's a real tell that the patient is at total lung capacity. And when you see that, time to say blow. Don't hold them there too long. Eyebrows often go up. But I think the key thing is that patients really don't look comfortable when they're at TLC, and there's a reason for that. They're not. You guys all do controls. You know it's not a comfortable place to live. So you don't want to keep a patient at TLC. Really going to tap you on the shoulder if I see you looking at the screen. I won't do it in front of the patient, but I'll let you know that, hey, you remember what I said about looking at the patient? I really want you to start doing that. You'll find yourself doing less efforts because you're spending less energy doing forced vital capacity maneuvers from less than TLC. You're going to be at a good starting point. Acceptable starter tests, we covered this just a little bit, and again emphasizing our embracing the standard of time to peak flow. It avoids that whole situation about higher flows on a less than explosive effort is given a fancy name called negative effort dependence of expiratory flow. And the patient population, once again, that you see this in is those that have lost elastic recoil. It has very little impact on the FEV1 of asthmatics, but still the standard that we want to. We don't have the liberty of saying, oh well, he didn't meet that standard, but it's okay, he's an asthmatic. As we know, very few patients have just one disease, or very many patients have more than one disease. It's a better way to say that. So you can have coexisting problems. So make sure that you're including time to peak flow problems, meaning when you don't meet that standard, that merits a place in your comments. Very, very important. So the end of test criteria has changed a little bit in terms of how they treated it verbally within the latest ATS standard document. They list two criteria, and they say when the patient can't or shouldn't continue for valid medical reasons, chief among them syncope, or when there's evidence of an expiratory plateau and the expiratory time is greater than 6 seconds in adults or kids over the age of 10. Now this plateau that they're talking about is, you're going to have varying abilities to be able to appreciate this depending upon the scale at which it's being presented. I'm a big fan of using the right click on Jaeger systems to maximize the volume time screen and have it fill your window so you can better appreciate this. But it's less important than just recognizing that the rate of change really does slow, and that in our laboratory, in the absence of an expiratory plateau, we'd really like to see you terminate the FVC at 15 seconds. That means that's your goal, and in failing to achieve that goal, try to get as close to it as you can, but try and get there safely. And while we're on that topic, I really want to sort of de-emphasize a previous practice we had of sort of quantifying how far or how close they got to that 15 second and sort of calling the degree of early termination. We really don't do that anymore. You really only want to call early termination in your comments when it looks like there's an abrupt end of test, when you can't see that coming to a plateau very soon and the expiratory time is short. So there's something that we do here at the main campus. I'm not sure if everybody else does this or not. That's why I'm mentioning it. Spirometry is generally safe. Its track record is such that, I think last year we did somewhere in the neighborhood of 27,000 spirometry tests in the laboratories that we manage. That's quite a few. But we're doing things a little bit differently. I think we may have had last year, for the first time in nearly 20 years, one patient had syncope or near syncope during a first forced vital capacity maneuver. Prior to that, we used to have about 10 to 15 a year doing about half that quantity of spirometry tests. The big change has been looking at end of test and saying, is it really necessary for the patient to do what ATS recommends, which is they say blow as hard as you possibly can and keep blowing as hard as you can until you can't blow any longer. And so we kind of looked at that and said, well, okay, well, what are we after? We know we're after the forced vital capacity. It's an important number. It's used as the denominator for the FEV1 to FEC ratio, which is how we identify obstruction. But we've already got the peak flow, we've already got the FEV1, and what we found was, somebody's causing an echo. There we go. Got it off. What we found was that there is a way where you can, in your instructions, tell the patient that at some point in the maneuver, you're going to be telling them to relax and push gently for the duration of the time. And further, that you'll count down the time remaining to 15 seconds. That helps the patient get to the FVC endpoint successfully, such that the last time I looked, in the patients that come to us for transplant, for example, that have obstructive lung disease as the primary reason, the average expiratory time in that patient population was 15 seconds, plus or minus a second. And so we're getting them there safely. We're only having them push for about 4 seconds. This is something that we did in our laboratory ages ago. And the red line there represents a pressure signal that was coming from an esophageal balloon positioned in the patient's thorax. So we had that in there. We were measuring transdiaphragmatic pressures. This was at a time when lung volume reduction surgery was in its infancy. Hadn't been regulated. This is before the NIH stepped in and said we need to study this. But we were looking to see who would be a good candidate for lung volume reduction surgery. And we thought, well, maybe assessing diaphragm strength in a really gold standard kind of way by measuring transdiaphragmatic pressure would be a good thing. So we had this catheter in here, and this, when you have an esophageal balloon catheter in, it's a good reflection of pleural pressure in an upright individual. And so this is a patient with severe emphysema, and you can see that at the peak of it's during a forced vital capacity maneuver. So looking at the red there, you can see a very sharp rise to a peak. Almost looks like a flow volume curve. But then the pressures were sustained during most of that forced exhalation, somewhere in the neighborhood of 30 to 40 centimeters of water pressure. And at the very end, probably when the patient was at the end of their rope, they gave it an additional push and raised the pressure just above 50 centimeters of water pressure. Now, keeping in mind that Valsalva maneuvers are sustained intrathoracic pressures of 40 centimeters of water pressure or above, and this is being sustained for 15 seconds. We looked at that and we said, oh, well, that explains why people pass out doing this test. We already knew that, but it was nice to see it quantified. And so what happens is that you really kind of do take the patient to the brink of what's considered to be safe. Every time you're doing a forced vital capacity maneuver that lasts that long, and you're asking the patient to push with maximum effort. So we kind of said, is Nancy on the call? She'll hate this, but so anyway, this is what happens, that when you're pushing, and you have a sustained elevated intrathoracic pressure, that causes the venous return to the heart to go down, cardiac output falls, systemic blood pressures fall, and that's what causes patients to get lightheaded, to cause them to faint. And if they don't do either one of those things, then they generally just don't feel good for a while. This is why we used to give long rest periods, why we still give rest periods in between each effort. Always asking the patient, do you feel okay to continue between every effort? That's a good safety practice to do. So this was a paper published a couple of years in the American Journal of Respiratory and Critical Care Medicine, and I'll send this slide set out to everybody on the call and in the region. So I encourage you to take a look at this and look at the notes that I put in under that. But the bullet points is that here's the start of our forced vital capacity over to the left there, and this patient was being monitored for a variety of other reasons, not just because they were curious about what happened during a forced vital capacity maneuver, but the second tracing up from the bottom is just what I showed you a moment ago, esophageal pressure. There shows it being sustained at around 50 centimeters of water pressure for most of that time. And if you go above that, you'll see what are the consequences on the patient's blood pressure.